Greetings, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations around the country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared on this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. My Bright Spots production team wants me to remind all of you to please rate and review the podcast. The more ratings, the more of your peers find the show, and the more bright spots that are shared on the show can be cloned around the country, improving healthcare for everyone and accomplishing the mission of the show. So we thank you in advance for taking 15 seconds on your podcast app to do that. The title of today's episode is How Banner Aetna is Rethinking Whole Person Care. And our guest today is Joanne Mizell, the Chief Operating Officer at Banner Aetna. Joanne joined the organization in February 2018 with over 20 years Aetna experience and nearly 30 years in the employee benefits industry. In this role, and as a member of the executive leadership team, Joanne oversees operations of the organization and supports the execution of strategic goals set by Banner Aetna's board of directors and their chief executive officer. Welcome to Bright Spots in Healthcare, Joanne.
Thank you, Eric. Thanks for having me.
I'm so glad. We've been trying to do this for a long time. I'm very excited about this conversation. So I want to let you kind of set the stage for all of us and explain to everyone who may not know or may not be very familiar with Banner Aetna, who is Banner Aetna and what makes your entire business model unique?
Sure, I'm happy to. I love talking about Banner Aetna. We are an insurance company, Arizona-based. So we're statewide in the state of Arizona. We were created in 2017 to as a joint venture. So for 5 years prior to that, Banner Health, the largest health system in Arizona, if you're not from here, and Aetna participated in a very successful ACO and decided they'd like to take things a little deeper. It was a great relationship, saw some really good results, and they decided they wanted to create a joint venture. So set up Banner Aetna as a separate insurance company. We're licensed again in the state of Arizona, and we are half owned by Banner Health and half owned by Aetna. And the reason Aetna already had a presence in Arizona, and Banner obviously had the market share, significant market share in Arizona, but the two organizations wanted to go deeper in the collaboration together to create improvements in a quicker time frame than they could do separately, trying to make change together, and improve the member and patient experience. And that was really the reason for creating the joint venture. So we had about 150,000 members when I joined 5 years ago. We are approaching 450,000 members. And we operate in the commercial and individual marketplace space, and again, are statewide. So that's kind of who we are and what we're trying to do. We're trying to make things better. Trying to find some bright spots using your podcast.
I love it, and I want to talk now a little bit more about how this unique joint venture is actually working, and we're going to get into some examples around that. So could you tell us a little bit about how Banner Aetna approaches whole person care at a high level? Because you do it in many ways similar to a lot of health plans, but with a little bit of a different twist, right?
Yes, I think we do approach it and have the infrastructure to do it as a health plan, because we're backed by Aetna, who's been doing health plan stuff for a long time. But it's the the change in the relationship with the health system, the major health system that we work with, that I think is what lays the groundwork for the difference in how we approach the whole health, because most health plans look at their members as members. And what that means is they become a member when they enroll in your plan, and you take care of them throughout the time they're a member, from paying for care and finding care and that sort of thing. But that you don't necessarily approach and look at how to approach them as a patient. And members become patients, and then become members again, depending on the care that they need for themselves and their families. And I think that what's really different, and what we found in the sweet spot for us, is that collaboration with the health system to look at that individual as a member and as a patient, but really as a person that's going to interact with all aspects of the health system and the payer system as the same person, right? So you're not, when you talk to a member and you talk to a patient, they're not two different people, right? They're the same person. So that's what we're looking to do. And then from a whole person, it's really about their health, their physical health, their mental health, which has become a lot more strained over the last few years for everyone, with everything that came with the pandemic. And then, but also there's the experience that's not clinical in nature. It's really how they experience the accessing and using the health system. So we have created some infrastructure. We've created some baseline programs to help support that, and have been building off of those since we started.
Could you talk a little bit about how you've organized your care teams in a way to take that sort of member-patient simultaneous approach, and a little bit about what you refer to as multidisciplinary care teams?
Yes. So our multidisciplinary care team is one of the first things we built as an organization. And the thought was, going into creating case management and care management and utilization and all of that health plans do, that's usually taken on by the payer. And it's to use the system the best you can. So make sure that your members are using care the best way for their well-being, as well as costs and everything that goes along with that. What we had the opportunity to do as a joint venture, though, was to say, we're an insurance company, and half of our company is owned by a health system. What if we had the health system do the care management for us, and do the utilization management and all of the programs, the clinical programs, to support our plan, and where the expertise is. That's what they do for a living. They know how to do that, and we give them the parameters and the guidelines and boundaries, and let them do what's right for the member. So that's what we did with MDCT. And what we also wanted to do is get away from the silos, where you work with a different person depending on what your clinical issue of the day is, or what your concern of the day is. And so we created this team that has a medical director, it has RNs, intake individuals, it has social workers, pharmacists, and dietitians, because we know how important that people eating right impacts their health, and they don't always know how to do that. So we created this team. And then the other thing we had the opportunity to do, because we're local here in Arizona, is to, instead of making it a telephonic thing where you're calling the intake person's calling the member and they're having these interactions over the phone, we had the opportunity to do face-to-face visits. So an intake individual would identify a member who's dealing with a lot of complex care, typically, and maybe having difficulty navigating the system. Then outreach is made to them, and through that conversation, you can kind of determine, well, you might need some assistance, or might benefit from some assistance from a social worker. You may have something in your home environment that makes it difficult to comply with your treatment plan for recovery. You may have dietary needs. You may have trouble understanding how to use how to take your prescriptions properly, and so you're not taking them, or you're not taking them properly. And based on that, the right individual will engage with that person. So there's a key lead who would be an RN. They'll come to your house and meet with you there, which is a great opportunity to assess the environment that that person's living in, from a safety hazard, from a chaos sometimes standpoint with things going on, and just from looking around at where there may be some limitations around, maybe there's food insecurity, or in Arizona it gets very hot in the summertime, and maybe you go to someone's house and you see they don't have air conditioning on, and there may be an issue, they can't afford to run that. So one of the other great things this team does is addresses some of those in what we call social determinants of health that may be getting in the way of that person's ability to get better and to comply with their treatment. So, it may mean we pay for an electric bill, or we help them catch up on their rent or something like that, so that they can really focus on their health and getting better. So that's kind of how that team works. We get referrals from physicians.
Let me pause real quick, Joanne, because I want to summarize that, because that was a lot. So I want to make sure we got it. First of all, you have an intake initially. You then do a home visit that's typically done by a nurse that allows you to look at the entire living environment, identify social health, and you have resources to potentially help with some of those social drivers that are maybe negatively impacting health. It's a team approach. On the team, you have the nurse, as it sounds like, sort of the captain, and then you have dietitians, a dietitian potentially, a licensed social worker, and a pharmacist you mentioned. As part of that. I think where you were going, and this is where I want to sort of make sure we hit next, is the referral patterns and ultimately where the primary care doctor fits into this. So I'd love to cover that. And then I want to get into financing and talk about how this gets budgeted and what sort of results are you kind of looking at to see if this type of program, we'll call it the MDCT, this multidisciplinary care team approach, how effective it is as a business model.
Okay. We think it's very effective, but I'll start with referral models. We get referrals from a lot of different places because we're so connected with the health system and the providers within that system. Providers know about the program. We coordinate with them and communicate with them frequently as reminders about the program. And we do get referrals directly from a physician where, they may have a patient who's having difficulty just really staying on track with what's going on with their care. The main place that we do get our referral and get our lists from is from data that we have as a payer. We know when someone's been in the hospital. We know when someone's had surgery. We know when someone is on certain specialty medications, and so that helps us to build our list to reach out to. That's probably the number one area, and then all of our other programs also feed into that. So we have a 24-hour nurse line, and they refer into this program if someone's calling, in off hours, or, they're having some difficulty that they realize they could benefit from, having an ongoing relationship with a nurse or social worker.
Can I ask you about that? Because I think sometimes when I talk to folks, the nurse line is like so 1990s, right? And in fact, what I'm hearing more and more is that the nurse line is actually having this rebirth of importance, because it ends up being the gateway to both virtual and bricks and mortar services, or just becomes a nice stopgap for a simple question, and how effective now the nurse line is, almost the advent of digital healthcare has made the nurse line even more valuable when at first glance you think, oh, we don't need a nurse line. You got like telemedicine. But in fact, the nurse line actually with telemedicine creates an accretive value. Can you speak to that very quickly?
Sure, sure. So our nurse on call is 24/7 and it is manned by Banner, by the health system. So it's not something that we've outsourced. It's actually within the health system. And I think you're right. It's more of a navigator, I think, for us a little bit more than really quick answers kind of thing. They can help make appointments. Give that person who's calling them with a question, here's what's going on right now. Should I go to the emergency room? They could tell them, here's what, here's my suggestion, based on what you've shared with me. And let's follow up with your primary care. Well, I don't have a primary care. Well, let me make an appointment for you. And they can go into the scheduler, which is very unique for this kind of a program. That nurse on call can go in and help make an appointment for that person so that they don't feel better in the morning and forget about follow-up care, right? So it is evolving. And I think that our program, again, because of that deep integration, has a little bit of additional value for our members.
And as far as the primary care's ongoing back and forth with this multidisciplinary care team, once that referral's made, once someone's in the program, how does that ongoing collaboration with the care team and PCP, how does that go? Because they feel like, as you talk about it, as sort of separate entities, team here, PCP over here. Those listening can see my hands just above. Talk to me about that collaboration.
Yeah, and that's a line that you kind of have to balance, because the primary care physicians don't have all this extra time outside of seeing patients to be interacting with our nurses. So it's really, if they have questions, if they have follow-up, once they've referred someone to us, they'll reach out. But for the most part, it's keeping them up to speed on what we're doing for their patient, or if we have a suggestion through the pharmacist that maybe there's a change made to their medications, because when we were having a meeting with them in their home, we noticed they were having dizzy spells or having some kind of a reaction that they might not have told them about. So it's more our team reaching out to them when there's something important to say. But I think for the most part, the physicians would rather not hear from anyone, because then they know that their patient's being taken care of. And they know what they've told their patient to do. And if they're not getting calls at their office with, they're having difficulties, then, and they know that there's somebody looking after them, they're happy to know that and assume that the patient is doing well with their care plan.
Now, because you're in this like payvider model, if you will, is everyone on the same EMR, or how is that information being shared across platforms?
Not necessarily. Our owner, all of their owned and employed providers are on the same EMR, but they also have Banner Health Network, which is a bunch of affiliate doctors that are on 30 some different EMRs. Banner has a connector for that through a company where they send back through InNote between EMRs and are able to share information. And we are getting into that now too, where our virtual care organization now sends care plans back to the Banner EMR for those Banner patients. So we are sending information back and forth, just not directly on the native EMR.
Now, let's talk about budget, because I think you told me when we prepped for this, the budget's sort of per member. And I just wanted to get a sense of like how you think about the budget for this and how do you recognize the savings for this?
So the way the model works and how it's funded is one thing, Banner Aetna, we don't believe in trying things out with your self-funded customers and let them see if it works or doesn't work. When we're going to pilot something, or if we believe in it, we put it in our fully insured plans. And that's what we initially did. We make them available to our self-funded customers as well. But that's what we do. So Banner staffs the entire MDCT, and they send us a bill every month for expenses to cover that team, and so we pay them directly. There's no markup, as we just pay the bills for staffing that team. I think the budget you're talking about is when we do have an item outside of typical medical care, for the we call it Nurses Without Boundaries program, because we want them to know this is a pot of money you can spend to help your patient. There's an IRS limit for that, and so I believe it may have gone up this year, but I believe it's around $600 per member. We don't want to create something that's going to be taxable for our patient or for our member, right? So we keep it within that, and most of the time it works. And we come in way under budget on that. So we don't do any kind of an ROI estimate or anything around that. That to us is really helping that member to be healthier. And did it help them adhere to their plan, or didn't it? It's just the right thing to do, and it's not overly cost prohibitive. But I think you're asking, how do we measure the effectiveness of the MDCT? And we're undergoing a study right now. But the last study we did was a 2-year study. And what we're looking at is, once we engage a member, and by engage, I mean that intake person calls them and says, hey, we have this program available to you, get some information. They say, yes, I'd like to participate. I'd like to talk to somebody and help me with what I'm going through. We consider them engaged at that point. They're having the meetings or calls. Nowadays, they're wanting to do a lot more virtual. So that's an engaged member. And we look at that population compared to a similar demographics and health status, and come up with a savings amount. And what we found in our last study was it was just over $900 per member per month savings for those members who did engage in the program, as compared with the control group that did not.
Oh, that's super cool.
Super cool. And that's just the financial. You talk about the bright spots. We have tons of testimonials from people that say, I spend 15 minutes with my doctor and he tells me all these things I need to do, but I get home and I don't know how to do it, and I don't know the right things to do. And that it just it's nice having someone there that helps them become healthy again. So that's really nice.
One of the things, like, to spread like a bright spot, to have it go viral, is it sort of has to be this leverageable, scalable kind of tactic or strategy. And so it's clear that the success of the MDCT, Multidisciplinary Care Team, for those of you who are getting confused by the acronym, that the key is the relationship between the provider and the payer. So my guess is some listeners are thinking, geez, we're not owned by a health system. We may not be able to pull this off. But I'm wondering, because I'd like you to kind of dispute that a bit and talk about what makes the successful payer and provider relationship that would enable anyone at a health plan listening to this to execute the same kind of program.
I think a health plan could implement a program like this within their organization. And, you can hire these RNs and dietitians and social workers and so forth to be part of that team. I think that making the investment in face-to-face, you can do that without being part of a joint venture kind of arrangement. And that face-to-face, really, it's kind of surprising how much that adds to the connection with that person who's there helping them. Looking at their facial expressions, seeing that they're actually listening to you, they're hearing what you have to say. Those things I don't think you need a joint venture for. I think that the level of effectiveness that we've been able to get, I think, would be a little more difficult without having that, really full integration between the payer and the system. But I do think that you can create an environment that looks like that outside of a joint venture. One of the things that I think creates a little more trust between the team and the member or patient is they are an employee of the health system, right? As opposed to insurance. Insurance is trying to take something away from me. So if you can get across that you really are there to help and not to take away their benefits or not to, be cheap on them, that showing them those that you care, that could be done also. And then again, the uh, the non-medical fund that's available,
So
that's something you don't expect to hear from your insurer, and it's not that expensive. And for the most part, people don't need it. But when they do, wow, my insurance company gave me money to pay my electric bill. That's just, it builds that trust, and anyone can do that.
So there's potentially a business case to invest. It's probably, I don't know what the return will be, how long that will take, but it sounds like, being able to invest in the team, then invest in face-to-face visits, and then invest in a non-medical fund to address social drivers are three key components to making sure you could build this program, whether you're part of a health system or not.
Yeah, I think you could do that, and would elevate a program beyond what a typical care management program within a payer would be.
I want to transition to some of the cool programs you have in place to address chronic illnesses. Before I do that, I want to take a quick moment to let everyone know about an exciting live event that Bright Spots in Healthcare is hosting and producing this summer, August 24th and 25th. It's a live in-person forum at the Marriott Long Wharf, right on the shores of Boston Harbor in Boston, Massachusetts. And we are calling it an unconference. I'll explain what that means, or maybe more traditionally a roundtable summit. It's being called Bright Spots in Care Models and Consumer Engagement, with a focus on health equity, hybrid care, and local as a strategy. And we are super excited to be doing this. We already have a great group of executives from health plans and providers confirmed as our featured panelists and guests. We're still bringing on some more as we speak. And beyond the talent of our executives leading that are going to be part of these panels, the event is extra special, I would say, for two reasons. One, there's no PowerPoint presentations. That's what we mean by an unconference. It's just going to be panels that you traditionally hear me moderate at Bright Spots in Healthcare. And then we're going to break every single guest into roundtable discussions with a facilitator. And the second thing that makes this event important is it's for payers, providers, community-based organizations, and select sponsors only. So it's going to be small, it's going to be intimate. And why this is important for everyone listening is when you go to speak at a conference, when you go to attend a conference, you need to justify to your board of directors or to your CEO the time and money that you are allocating to go to such an event. And you need to do this through the new ideas, the new insights, and or the new connections you've made at these events. And this is more often done successfully through networking and peer-to-peer discussions than just listening to presentations for 2 days. And it's certainly going to be easier to accomplish this at the type of event that we are designing for you in August at a large expo. So it's an event designed around plenary panels, not unlike, like I said, the ones you listen to on the show, and then facilitated roundtables with other attendees. And it's a combination of gaining insights from those executive thought leaders like you are today, and then having a more in-depth, intimate conversations with other health plan and provider and CBO leaders through these roundtable discussions for the day and a half. So it's going to be a lot of fun. It's going to be not too formal, but very focused and productive in discussions around those important topics that I mentioned earlier. So if you'd like to register or get more information, you can go to brightspotsinhealthcare.com or simply email me directly at eglazer@sharedpurposeconnect.com, and we'll put that contact information right in today's show description. All right, and Joanne, I'm going to be talking to you about that too, because I'd love to get you on a panel there. But so let's talk about some of the bright spots in chronic care and how you're delivering programs to support your members with comorbidities. And what is Banner Aetna's overall philosophy around whole person care, and what makes your organization different?
So I mean, like I said before, whole person, that's what you're dealing with. Like most people that have chronic conditions also are dealing with some kind of anxiety or some level of depression or things like that. So I do think that the concept of whole person care is being more widely accepted and recognized as important to all aspects of someone's health, right? So our again with whole person care, we kind of start with our MDCT, that core team of people, and build out from there. So, like you mentioned, Eric, earlier, we do have some care management programs around specific conditions, and one of them that we really attacked early was for people living with type 2 diabetes. So I'll talk about that in a minute, but I think that again, we're in such a great position to have that collaboration with the health system. Right before I came to do this recording with you, I was in a meeting with Banner Health and Aetna and CVS and doing some strategy around some pharmacy. And having everyone at the table really does give you that ability to look at all aspects of the person and how they get care, whether it's from through medication, from treatment, from mental health and emotional assistance and things like that. So we're trying to, number one, build all of our programs around the multidisciplinary care team, connect them with that team so that we see a 360 view of somebody, and then build programs that also feed into and feed out of that team. So keeping everything very close. The technology isn't always easy, but being as connected as joint owners, we are able to stand up some technology to make sure that information is flowing well between the organizations. So it's kind of just all builds from that team. The multidisciplinary care team does look at that whole person, but there are times when you need a little more care in one area or another.
So you mentioned this diabetes reversal program. Let's put it into context. Let's hear a little bit about what about that program specifically.
Sure. So we have been looking for, well, probably the last 3 years, as we've seen the impact and the number of members that have type 2 diabetes continue to increase. We're really at about 10% nationally of all adults are diagnosed with diabetes, and that doesn't even count those that aren't diagnosed, right? So it's a pretty high percentage of our population as well. So we were looking at diabetes management programs, and we talked to startups, we talked to everyone. We talked to Banner Health, our owner on the health system side. We talked to Aetna for programs they're looking at, and really wanted to find the most effective diabetes management program. What we came across was a type 2 diabetes reversal program, which really spoke to us, because all of the other programs were around managing your diabetes, making sure that you're getting your A1C tested, making sure you're taking your medications and your insulin and seeing your doctor and everything that goes along with that and being compliant. But we found one that was looking at and had proven results in reversing type 2 diabetes. So of course, everyone, both of our owners, raised their flags. You can't reverse diabetes. That's crazy. That's something you need to manage the best way you can. And so we underwent a pilot, and for a year. We managed that pilot with a specified group of our membership, about 100,000 members, so a good size portion. And in 1 year in this program, A1C dropped on average 1 point. So that's significant for 1 year. Weight loss, 10.7% average weight loss in that period of a year. And the other measure that we look at is that I think really you can call reversal is when you start taking away or reducing medication. And we saw in that 1 year pilot a 54% reduction in prescription drugs. And that's probably the biggest thing that the members that participated appreciated, because they don't want to be, taking insulin all the time and just all the medications that go with diabetes. Seeing that reduced, and along with the weight loss and what that means to their lifestyle was huge. That was our 1 year pilot.
I love it. One of the things, I know we're getting tight on time here, so I want you to tell me a little bit about how you build upon such success. As you sit there as the leader, one of the leaders of the organization, you're having success, providing innovative solutions to endless diabetes. Chronic illness is obviously a problem that we've been grappling with before time, almost, maybe not exactly before time, but at least before Fritos and French fries. And so how have you built upon this program and built other programs that are innovative and aligned with this culture?
Mm-hmm. This program, we wanted to prove that it actually could be reversed for some of our members. So we did that pilot. We also went another 6 months with the entire group. Again, all our fully insured business, because we believe in it, so we're paying for it. But the next things we're looking at is applying the principles of this program, a lot of which are behavioral, and the way people get attached to food and why certain triggers and that sort of thing, and look at pre-diabetics next. So let's catch them before. And people say that's kind of not really something a payer would normally do, because when they're pre-diabetic, they're not really costing you a lot of money, and they may be gone next year, right, when they turn diabetic and you've helped someone else. But it is something we fortunately do have good retention rates with our membership. And so pre-diabetes is the next thing we're looking into. And we're pretty good about doing our due diligence and making sure we're understanding what's happening and what period of time we need to measure and find results and how to do that. So that would be the next thing, as well as, maybe a program like this just for obesity, even before you're pre-diabetic. Let's get you really early. That's another epidemic that we're dealing with is obesity that leads to pre-diabetes, that leads to diabetes, right? So that's kind of what we're looking at with that program specifically. But again, sticking with the diabetes focus, not everyone responds the same way to every program. So another pilot that you and I talked about before that we have now rolled out, we call it the Banner Aetna Kitchen. Do you want me to talk about that a little bit?
That's okay. Loving this. Go ahead. That's what I'm waiting for.
So the Banner Aetna Kitchen is what we call it. It's kind of hokey sounding, but we did a pilot in 2021 where we reached out to our type 2 diabetics and identified who those adults were, and invited them to participate in a cooking class. And we actually call them dinner parties, hosted at a culinary institute, one of the main culinary institutes here in Arizona, by a trained chef. We had a dietitian from our MDCT participate in each of those sessions. And the whole idea is to create a community. So all of these type 2 diabetics, they're working, they're busy, they have families, everyone in the family wants to eat something different. You bring them into this class, teach them how to cook a healthy meal and why it's important. And so while the chef's cooking and helping them chop and do what they need to do, the dietitian's engaging them and asking questions like, how would you normally do this? And really kind of making it fun. They laugh a lot, they interact with each other. And it's a 12-week program. Twice a month, they come and do this. And at the end of the dinner party, they eat what they cooked, and then they're giving each person a bag of groceries to take home and make the meal for their family. And we've ended up doing, I think, 5 classes after the pilot sessions. We're just finishing up our first one this year, and we actually have had people come back, and we've now given them official names as ambassadors that said, I want to come back and do this again and help other people. And that's just, to me, like, who asks to come and help and take their own time to help other people because they got so much out of it. So we have these official ambassadors, and they send emails to the group, and it's encouraging, and it's just really kind of grown from where we started with let's help people figure out how to make healthy food to creating a community. And then beyond that, it's like a kind of a gateway into our other programs. So the dietitians are there and referring people into the MDCT or referring them into our diabetes reversal program. And then they're in one of those programs and someone hears something and they come back through. So it's one of my favorite things that we've done here, because we're not measuring how much money we saved. There's not an ROI. It's about the experience that these people are having. And, one of the things that we're trying to do is make their lives better. And we are actually making their lives better.
Yeah, I love when you're able to sort of create a business case for a program that as a standalone may be too costly on its own to necessarily warrant the time and energy. And then when you put it into a larger part of a strategy, it becomes very accretive with everything else you're doing. So when you think about the peer-to-peer interaction in of itself is going to drive better A1C results and weight loss results, and that overall peer support's been a proven entity to help with any kind of chronic illness if run correctly. The obviously using food as a lever to do that and making cooking healthy food fun is so great. And then be able to integrate the multidisciplinary care team approach and everything you're doing with diabetes reversal. It's brilliant. I love it. How do you scale that? Like, how do you make it spread it around without, costing too much? Like, how does this become scalable for all of you?
Yeah, that's the toughest thing about it, because to keep it the intimate dinner parties that they are today with a small group of people, it's we're expanding this year to 4 sessions. We had three last year and 2 the year before, so we're adding more sessions. But I am hesitant to really scale it too fast, because what we have is just so great. And I don't want to lose any of that by having, doubling the size of the classes and making it less interactive. And then you start having little cliques within the classes and not the whole group working together. So we're continuing to add, we're going to add another culinary institute this year to another part of town. Part of it is Arizona's a big state, and people aren't going to drive all over the state to go to a dinner party on a Wednesday. So we have to reach out to people who are within reasonable proximity of the Culinary Institute. So that's another thing that we are expanding it that way. But I'm not in a hurry to make it, a huge scale, because I do think we'll lose something by doing that. And, this is why we have the different programs. So people can, try each one and hopefully become healthier by the end. And by the way, on the Banner Aetna Kitchen, in that the pilot period, self-reported, of course, we had an average A1C reduction of 1.6 points.
Wow.
And weight loss average of 8 pounds. And 6 months later, we went back and checked in again, and the majority of that was maintained. So that's the other thing. And maybe this isn't scalable, but it's expanding its reach. We've had a number of participants bring family members back with them to the class, their daughters or their spouse, to learn with them, and are, getting the whole family involved at home, which is just, that's the way to make it work, right? You have to get the whole family on board that they're going to eat something and not fight it.
Yeah, I'm struggling with what question to ask next, because I see the time and I want to make sure we stay on time. So why don't you mention very quickly a spin-off program from the cooking program that you've launched? But really, I'd like to get into the key tenets to building such innovative programs, and sort of, put your, professor at, business school, executive business school in place, and tell our audience, what would be the blueprint to building an innovative whole person care program?
Sure. So I think the spinoff you're referring to is the gardening days. And this is part of what we created. Each of the culinary institutes have a nice big garden outside. So we added 2 days to each of the sessions, where on a Saturday, the participants come and they learn how to garden. They learn how to grow certain things that they can take home with seeds and soil and, potting, and grow at home. So herbs, small things like that. So that has been surprisingly, given that it's on Saturday, to me, very surprisingly well attended by those participants. And, we'll keep doing things like that as we come up with new ideas to make it better.
Great. Love the innovation. What about the blueprint? Like how do folks listening think about strategically creating, innovative programs like this? I know we talked about some of the core tenets of the multidisciplinary care team approach. What about in general tenets to drive such innovation?
Yeah, I in thinking about that in retrospect, based on what we've done and looking back, I would say that to really have your foundation strong, you have to have the engagement of a health system, the health system that's touching the majority of your members. And I honestly, before you start building programs like we have, I think that relationship has to be built. Because right now, for most who aren't in a joint venture relationship or even in an ACO, the relationship between payer and health system is adversarial. It's, you're not paying me enough. I'm paying you too much. You're doing too many services, that sort of thing. I think that the building of the trust and getting agreement in advance and alignment on what you want to achieve, documenting it. We had a very extensive business plan for Banner Aetna. Doesn't have to be a joint venture, but about what both organizations are going to do, what they're going to commit to, if not very specific points, what they're going to commit to in terms of supporting certain activities. I think that's really where you have to start, is building that foundation that way, and assigning responsible parties at an executive level in both organizations to ensure that those things happen, and potentially even having some financial reward or penalties at the end. Hopefully rewards, because we don't want to be non-adversarial. I really don't know that you can do these things without, because the programs I've talked about, the MDCT, we built with Banner Health, right? And we did that. The type 2 diabetes reversal program, we vendored. we looked at both organizations, and everyone, they are agreeable that we could find another one that works, and we're going to use a vendor. And then the Banner Aetna Kitchen we developed internally with some of our partners from Aetna and from Banner, but we're all going in the same direction to do the same thing, which is improve the member experience and member health within the overall system. And without that upfront alignment, I think that's worth spending a year or whatever it takes together at the executive level to create that vision and get alignment on that vision.
Is there anything, once that partnership seems strong enough, is there anything about where you sort of drill for oil, where you really want to focus that first innovative effort? How did you go about determining sort of where you wanted to sort of strike?
Yeah. I think it's really inventorying the strengths of both organizations and agreeing that one is better than the other at certain things. And what we did with the clinical programs and the care management, one of the first things we did was start building out that multidisciplinary care team with people who are clinical. They don't do insurance. They don't know insurance. They're all about taking care of the members. So many great ideas come from that team and from the intimate conversations they're having with patients about their needs that wouldn't typically get back to the payer. But we learn from it, and we create new extensions on the programs and new additions from there.
So that's great. I'm gonna summarize. It sounds like the healthcare forming a partnership between healthcare system and payer, and that relationship building and that sort of common objective is so key. And with that,
trust.
Yeah, common interests, and then aligning on the goals, documenting it, including commitments to the programs that get spawned from the partnership, maybe even putting in carrots and sticks within that, so it's all written down and documented. And then finally, when that partnership is created, inventorying the strengths and weaknesses, and then determining how to leverage those strengths to drive better results in an area with the consumer's best interests in mind.
Yep, exactly.
This was great. I wish we had more time. Where can people find you? Where can they learn more about these programs?
BannerAetna.com. We have a website, and you're welcome to go there and just look at about us, read our press releases, and you even may find this podcast link on BannerAetna.com.
That's awesome. Thank you for the time you took to prepare with me, and just for your overall time today. It was great. My message to everyone listening: use the strategy of looking for bright spots and things working well among the chaos in healthcare, to ignore all the noise and focus on the tactics that are actually generating positive results, and maybe scaling those creates an entire solution strategy to your organization's toughest challenges, like how to innovate around whole person care, and drive better results among some of your toughest members, right? The comorbidities, the chronically ill, folks suffering from diabetes. So we hope that you use some of the bright spots shared today to inspire your thinking at your organization, and maybe even enhance your organization's current approach to improving healthcare for consumers everywhere. Thank you for listening. This is your Bright Spots in Healthcare podcast.